Hello, I'm Melissa Walton-Shirley, and thanks for joining us today on theheart.org. We have with us Dr. Jim Stein, Dr. Pamela Douglas. We're going to be having a casual conversation about prevention and imaging today, so thanks for joining me. Appreciate your time very much. I thought it was really interesting because most of us are now using calcium scoring, and we saw information this week about how patients who were actually shown their images that were abnormal were prompted to engage in prevention. So, Dr. Douglas, can you tell me about what you thought about that trial?
Well, this has been something that people, a hypothesis that we have had, that if you provide patients with more data, that they will change their lifestyles. And we haven't had good verification of that. And this is really the first time that showed that patients were more compliant. And you have to ask, is this because the patients were more compliant? Because the doctors felt this was a more believable manifestation of atherosclerosis than just simply having a Framingham risk score, or what's there in the mix that was different this time in this study from what we've seen before.
And then can you tell me what you think about the patient who saw that their score was normal, but they have all these risk factors, and now they're not willing to engage because they walk away thinking, I'm okay, I don't need any of that stuff?
Well, that's really an important point. I think the first thing to realize is that the report at this meeting was an observational report, and there have been many observational reports showing that if you have calcium, you may be more likely to engage in healthy behaviors. But when we randomize things, we find, like Pam said, that it really depends more on what the doctor says and what the messages are. And there's this risk then, too, which is that if someone has a calcium score of 0, which we know, for example, 50% of white women under the age of 65 will have a calcium score of 0, that they'll walk away and say, oh, no calcium, no disease, and I don't have to engage in healthy behaviors. The other risk, of course, is pseudo-disease. Having calcium doesn't mean you have coronary disease. It means you have calcium. And although your risk is increased, an increase in risk for someone who's otherwise at low risk may not be important. And for someone who's at high risk, well, an increased risk still makes them at high risk. So I think the story is really unclear.
So, Pamela, what do you say to a patient that walks out and says, you know, my calcium score is 0, I'm not going to do anything about it, but they're diabetic and they're smokers? Where does the conversation go from there?
Well, there's a number of places it can go. One is that the treatment of risk factors when they're present is tried and true, proven over and over and over again. Another place it can go is that there's a significant percentage of individuals with 0 calcium scores who actually have atherosclerosis and who subsequently have events. And this is particularly true in women as compared to men, in some racial and ethnic minorities in this country that tend to have non-calcified plaque rather than calcified plaque. And the third thing that I would say, which echoes what Jim just said, it's not the calcified plaque that's the problem. The plaque that ruptures is generally the non-calcified plaque that we don't see. And the reason the calcium score works as a predictive tool is that they come together. But just because you don't have one doesn't mean you don't have the other.
You know, I had a very interesting patient who was in her 70s. She's African American. She had what I thought was angina. She resisted stress testing at first. I did it. I medicated her because she had very mild ischemia. She would not have a cath despite the fact that her symptoms were progressive. I thought, well, I'll show her a calcium score and wow her with that information, and she'll go ahead and get on the cath table. It was 14. So 2 to 3 months go by. She's taking more and more nitrates, and I finally convinced her to have a cath, and she had a pretty tight LAD. So that I learned my lesson about hanging my hat completely on calcium scoring. So I have a question now about CT angiography. I don't really know how to utilize it because I'm in one of those places where we don't have it. So I've reserved it for patients where the stress testing is sort of equivocal. Maybe the patient is concerned about having a cath, and I'm convinced that they need to have it, and I try to use that to push them toward it. So how do you employ CT angiography, and does the calcium score affect your decision-making process?
So I don't do much in the way of calcium scores anymore because the CT angiogram has gotten so much better in terms of radiation dose and the prices come down. And I figure you're getting a lot more information for about the same effort. If you're in an institution that can do a sub 5 millisievert scan and even some single digit, below 1 millisievert, as opposed to initially much higher doses. So the radiation cost is less than it used to be. The calcium score is still quite a bit less, but it's certainly less than a nuclear scan. And we're seeing that in national registries and trials. It's not just the academic centers. So I think a lot of the concern about radiation risk is CT scan has been removed. There's concerns about costs have been removed as an initial test. That said, everything we know about whether or not you need to treat coronary disease mechanically, whether it's a revascular percutaneous or surgical revascularization, is based on presence of ischemia. And CT angiogram provides us with anatomy now and not ischemia. In the future, we may learn more about perfusion from CT scans, but right now we don't have that information. And so I still rely very heavily on identification of ischemia, because not every lesion is significant, and we know from the FAME study that dilating tight but non-physiologically important lesions is not healthy. Does not provide a better outcome, provides a worse outcome.
Unfortunately.
Yeah.
I saw some really interesting information, I guess it was about 3 years ago, about marrying imaging for vulnerable plaque with CT angiography. So are you aware of any studies that are going to present soon about that information?
Right now I'm not aware of any immediate studies that are going to change our ability to identify plaques and marry that information to anatomic data. But I think that's the future. What we really need to do is to be able to better understand coronary physiology in addition to anatomy. And there are some great studies that have just come out in the past year looking at computerized based techniques to look at flow reserve non-invasively. And when you can do CT-based or MR-based coronary flow reserve and then look at coronary anatomy, you basically have the FAME trial in conjunction with a diagnostic cardiac cath, and with your history, you really know a lot about your patient. And Pam really hit the nail on the head, which is that with the decreased radiation burden associated with CT angiography and the decreased cost, it's becoming a dominant methodology in treatment of cardiac patients, and it's only going to get better. In some of the large population-based studies, 95% of patients can get their CT angio done with less than 5 millisieverts. That's less than a radionuclide stress test, less than a cath.
Much better.
Yeah.
And I guess the vulnerable plaque issue is one of the many holy grails of cardiology right now that we just have to wait for. I have a question for you, Dr. Stein. Now that we sort of are told that primary prevention and statins really they don't belong together perhaps, and I don't know that you agree with that notion. What if you have a 58-year-old patient whose family history was such that her father maybe had an infarction at age 38, she's postmenopausal, she's been on a statin now for 5 years, but her calcium score is low and she feels well and her images are negative. Would you then recommend that she stop her statin therapy?
Well, that's a great question. So first off, I don't agree for a minute that statins and primary prevention don't go together. And I just want to say that loud and say it for the record. We know that atherosclerosis is atherosclerosis, and a 59-year-old woman with diabetes and an MI is really no different than a 58-year-old woman with impaired fasting glucose and overweightedness. It's just a difference of a year. And what we want to search for is the vulnerable patient, like the one you're talking about, short of finding the vulnerable plaque. So a woman like you told me about, I would not stop the patient's statin. In fact, I rarely stop people's statins simply because the risk factors that led us to start the statin tend to go forward. So people tend to get worse. And even if they get better, even if they change their lifestyle, they still get older. And age is the single biggest predictor. And what we've learned about statins over the past 30 years isn't just that they're effective, but it's also that they're incredibly safe. And the recent FDA advisory aside, I can't think of another class of medications that's safer and more effective than statins.
Dr. Douglas, what do you think about that?
I would tend to agree with Jim. I would hesitate to stop something that appears to be working that does not have side effects. And we do, it is a surrogate endpoint to look at a lipid profile. But it can be very reassuring. There's a lot of epidemiologic and trial data to say that that is highly predictive of risk.
Well, I appreciate your sitting down with us today to talk about these very important issues, and I'm sure more information to come at the next meeting. And thank you all very much for joining us today on theheart.org.